Next, Dr. Godoy will talk to us about how things look for non-muscle invasive bladder cancer with some new drugs available.
All right, good afternoon. Thanks so much, everyone, for the invitation, for the honor to be here one more year in the meeting. So moving forward towards the non-muscle invasive space, I have nothing, no disclosures related to this talk. And I'll start saying that we have had a lack of improvement and a lack of new therapies in bladder cancer overall for the past couple decades. In a non-muscle invasive disease, more than 20 years without new therapies, new treatments, nothing new coming up on the bladder. The mainstay for treatment was based on resection, the TURBT, and also the use of intravesical therapy, immunotherapy with BCG and interferon, and then intravesical chemotherapy agents. And when those failed, then the last resort was a cystectomy, and more recently we started adopting as well bladder preservation protocols with chemoradiation therapy. We were seeing the new era of non-muscle invasive bladder cancer emerging, and that's a combination of several factors. I think there's been a lot of research all these years, all these efforts coming, and the fruit of this research is actually showing up now. There's been more awareness and funding, and this is a lot of effort from the cooperative groups, the funding agencies, the FDA, the government agencies, also the advocacy groups, the whole academic community is getting together and putting more focus on this disease. And I would say the BCG shortage was the final push to all of this. So if anything good came out of the BCG shortage problem, is that it created an urgency for us to find alternative treatments and alternative therapies for these patients that cannot have BCG and really need it. So what we're seeing is multiple trials addressing both the BCG-naive and BCG-unresponsive disease states. We're seeing an increased utilization and different ways to utilize and deliver intravesical chemotherapy. And we're going to talk a lot about the doublets. You know, the Gemcitabine has become the de facto standard for these patients who either don't have BCG or fail BCG initially. We've seen the first intravenous therapy for non-muscle invasive disease with a pembrolizumab approved in early 2020. The first gene therapy for non-muscle invasive therapy approved just recently in December last year. And also a lot more therapies in the immuno-oncology area, checkpoint inhibitors, all focusing on the locally advanced and also metastatic disease. That's not the focus of this talk. So focusing on the non-muscle invasive space alone. So the tripod of management is based on the resection, on the clinical staging, and also the risk stratification. So I'm just going to review this very quickly. Those are the risk factors we typically use to risk stratify the patients, and that's what's going to base the whole therapy afterwards. So we look into clinical staging, grade, the size of the tumor, 3 centimeters being the cutoff, number of lesions, and also if the tumor is first or recurrent disease within a year. You're all very familiarized with this risk stratification table, and if the patients have all the risk factors in the good end of the spectrum, they are under the low risk category. If they have in the other end of the spectrum, they're the high risk category. In the middle, they are intermediate risk. So you can see the patients with a low grade disease, they can have T1 disease, they can have tumors greater than 3 centimeters, they can have multiple tumors, but not a lot of these risk factors combined. And even patients with a high grade, they can have a T1 lesion, but no greater than 3, not multiple, and not recurrent, and they still would be an intermediate risk. So why this is important? We know the high risk group are the ones with the higher risk. These tumors progress a lot more, and they're more risky for the patient. So that's why this has been the main focus of the research and the new trials and therapies coming up, although there's other therapies coming on intermediate risk as well. And when we talk about the high risk, under the very high risk, we're going to put attention on the BCG-unresponsive group, because that's also a very important unmet need that we have in this field. So what's the treatment for the BCG-unresponsive disease? So until recently, of course, we cannot avoid talking about cystectomy. We have always to have that discussion with the patients. Valrubicin was being approved as the first drug approved for this space more than 20 years ago, and the indications for patients with carcinoma in situ only, not papillary disease. We're going to show the data. We're going to review the data quickly. And then we have the pembrolizumab. So the study Keynote 57 was the one who proved the benefit using pembrolizumab. And the indication was for carcinoma in situ with or without papillary disease, high-grade disease, Ta or T1, in those patients who are either ineligible for cystectomy or who refuse cystectomy. So that's a very specific indication. And then the variations of chemotherapy, right? So you start using mitomycin, gemcitabine, different combinations, different delivery systems for those, and also the doublets, and of note, the Gemdosi, the most notable doublet there. So that's being shown so good results and good response in these patients that there are studies now moving Gemdosi doublets to the BCG naive space. So it's getting now up front and not only offered for patients who are BCG unresponsive. Then, as I mentioned, the gene therapy, first gene therapy approved. So the indication are for the BCG unresponsive with carcinoma in situ with or without papillary disease, Ta or T1, but can also be offered for patients with BCG unresponsive papillary disease, Ta or T1, without carcinoma in situ. So a little more broad indication there. So just going over the data quickly on these main therapies there for this space. So valrubicin, you see, it shows 10% response in 10 years, not very exciting. 4% at 2 years. That's the reason why it has not been utilized a lot. But at that time was the only therapy available, only therapy approved. The Keynote 57 employs the pembrolizumab, which is a PD-1 inhibitor. The dose is the 200 milligrams intravenous, infused every 3 weeks, and the duration of therapy is it's planned for 2 years, 24 months. With that study, they observed a 41% complete response with a median follow-up of 26 months. 48% maintained the disease, maintained the response greater than a year. And the median duration of response was 16 months, with a range going all the way to 30 months. So that led to the FDA approval, and this was early year 2020. This is just to show the baseline characteristics of the patients in the study, and you can see on your right-hand side, the rates of responses there. These are the tables, a lot better than valrubicin that we saw before, right? With a median duration of complete response of 16 months there, and the swimmers plot at the bottom showing the same data. With the COVID, we had some challenges with the distancing and the patients trying to avoid coming to clinic and all of that. So variations in the delivery were applied. So now we also have an alternative delivery, which is 400 milligrams, double the dose, offer every 6 weeks. And the duration is still the same. They should keep the therapy for 24 months, or if they have persistent or recurrent disease, progression, or limiting toxicity, whichever comes first. And another thing that is interesting, pembrolizumab has been used with a lot of other solid organ tumors, and for some of those, it's required to have PD-1 or PD-L1 testing as a criteria to offer the therapy. This does not happen with bladder. So you don't have to test, you don't have to check the expression of a PD-1 or PD-L1 in these tumors. So that led to another trial, very interesting, the Keynote 676 is a randomized open label. It's a comparator control phase 3 study, and it's comparing pembrolizumab with BCG versus BCG monotherapy. So very interesting design. This is focused on patients with a high risk, non-muscle invasive. We have persistent or recurrent disease after an initial induction with BCG. So this is not BCG unresponsive. It's just failed to one induction with BCG. So it's a different question than the BCG unresponsive. And the pembrolizumab is given at the classic dose, 35 cycles for 2 years total therapy. BCG uses a classic protocol from SWOG of induction and maintenance for the full 3 years, 36 months. You see the stratification for the study using the presence of carcinoma in situ, the expression of a PD-L1, and also the history of a previous treatments for the bladder cancer. And they're planning to accrue 550 subjects with no more than 182 without carcinoma in situ, because the carcinoma in situ alone is a very important group so we can compare response. So it's very important for the endpoint in this study. And the primary endpoint is complete response in this carcinoma in situ group, with secondary endpoint being event-free survival 12 years, recurrence-free survival, overall disease-specific survival, time to cystectomy, duration of response, all those things. This is the study design. Very simple, very straightforward, but is addressing a very important question on these patients that you can see here. They can be persistent or recurrence between 0 and 6 months. They can have the same status between 6 and 12 months, or even greater than 12 months. So it's a different question than we're trying to address if the BCG are responsive. How about gemcitabine? With the background of BCG shortage and a lot of people trying to find alternatives and using gemcitabine in these patients, this is a retrospective cohort study. University of Iowa, they're looking at their history and all the patients treated. It was over 300 patients, same thing, enormous invasive bladder cancer, and they were treatment naive, meaning they didn't have BCG available, so they're offering whatever they have, so it was gemcitabine in that case. And then they compare 174 patients who received BCG primarily versus 138 who received the sequential gemcitabine and docetaxel. The median follow-up was a little bit different. It was 24 months for gemcitabine group versus 49 months for the BCG. So that impacted a little bit the analysis for the long-term oncological survival. But the protocol is very standard. The BCG was given under the SWOG protocol. They were still using interferon. So some of these patients in the BCG arm, they had BCG plus interferon. And gemcitabine was given sequentially. So this is given like a 1 gram of BCG diluted in 50 cc's of saline. You leave it dwell in the bladder for 90 minutes. You drain the bladder, and then you deliver the docetaxel. The dose is 37.5 milligrams diluted in 50 cc's of normal saline. And then the dwell time might vary depending on the protocol, can go from 90 minutes to 120 minutes. And this is given as an induction setting once a week for 6 consecutive weeks, and then on a maintenance on a monthly installations for 2 years, 24 months. This is the data. I'm a little bit busy, but just to show the estimates of survival rates at different time points, 6 months, 12 months, 24 and 36 months for the different time points. So you see on the lines, recurrence-free survival, high-grade recurrence-free survival, progression-free survival, and then overall survival and specific survival. You can see for the high-grade recurrence-free survival, this separation of the curves with the benefit to the gemcitabine protocol is very, very impressive. And here you can also see the benefit in terms of the hazard ratio in comparison with BCG. So based on, and again, the adverse events, very tolerable, no grade 4 or grade 5 toxicity in the gemcitabine group, very minimal and tolerable grade 3 toxicity. So it seems to be very tolerable regimen there. Apparently, gemcitabine group had more bladder spasms than BCG. The patients in the BCG group had more dysuria, and the BCG group has some more ultrarargia as well. So that led to an ongoing phase 3 trial. It's from the ECOG group, the EA8212, and the acronym for that study is BRIDGE, and that's ongoing. It's comparing on the BCG naive population, gemcitabine versus BCG. So very interesting data coming up. This is data presented at the UASCO earlier this year. Different group was looking at a prospective study. This is a phase 2, so a smaller study. They accrue only 25 patients. But again, looking at the benefit of this combination in the BCG naive space, and dosing a little bit different. They were giving 40 milligrams of a docetaxel for these patients, but in the same format, 6 weekly installations for induction, and then monthly installations for 2 years on the maintenance, and very promising early results. You can see the response rates, complete response rates at 3 months, very impressive. They seem to be fairly durable at 12 months, also with very little toxicity. So stay tuned. very likely this is going to jump into the early space on the BCG naive to compete with BCG or even replace BCG if we have, continuing this shortage era. So let's talk about the gene therapy now, the new kid on the block. So this was the study published on the Lancet Oncology 2021. And what is this drug? It's a non-replicating recombinant adenovirus vector-based gene therapy. So it's gene therapy. It uses an adenovirus as a vector to transduce this gene, is a copy of the interferon alpha 2b gene into the endothelial cells. So we know interferon works very well. The problem with instilling interferon in the bladder is just staying dwelling there for an hour or two, so it has some response, but then goes away immediately. This way, you get interferon in the cells, it lasts longer, and then you have much more effective and durable response. And they also added the SYN3, which is a surfactant that just increases and optimizes the transduction of this gene into the endothelium. So was a US multi-center study, was a prospective study, open label, in a phase 3 format. They're focusing on the BCG-unresponsive group, and this therapy is delivered intravesically on one instillation every 3 months. Very convenient. Interbladder instillation, stays in the bladder dwelling for 1 hour, and that's it. 3 months later, the patient come again, and then they keep repeating every 3 months. The duration of therapy was for a year, but the patients are offered, the ones who had good response, they're offered to continue on the maintenance, keep having new instillations every 3 months after that. And these patients in the study had a mandatory biopsy at 12 months because that was an important endpoint there. So you can see the primary endpoint was complete response at any time in the group who had carcinoma in situ only, and they were actually looking at the carcinoma in situ plus minus Ta/T1 papillary disease. As you can see here, they enroll over 150 patients, and they had a 53.4% response in the group with carcinoma in situ at 3 months. And of those, 46% maintained the same response at 12 months. So very durable. The median duration was 9.7 months for the therapy. They've seen 0 deaths. 95% of these patients never progressed to muscle invasive state. 74 were free from cystectomy at 1 year. And 36% of these patients who had initial CIS, good response at 3 months, they still were negative from high-grade recurrence at 2 years' time. So a lot better duration and results that we see in comparison with the other studies. So this led to the FDA approval last December, and they get the priority reviews, the breakthrough therapy, fast-track statuses, and has been fast incorporated into the guidelines. So this is just to show the tables and show the data. You can see here on the left the carcinoma in situ alone group, the high-grade papillary group on the right, and then at the far column on the right, you see all the patients combined with their rates of response and then duration of response, and then at the bottom, the rates at 3, 9, and 12 months. These are the curves, again, much better than the previous therapies and the other therapies we had so far. And in terms of toxicity, it's very well tolerable. No grade 4 or 5, very minimal, very manageable grade 3 toxicities. So it seems very, very promising. So I'll conclude bringing now guidelines. So this is the NCCN, the newest version. And then you can see the risk stratification-based treatment there for low, intermediate, and high risk. BCG is still a key factor in stratifying patients and who receives the initial therapy and then who fails. But you start seeing those boxes getting populated with new therapies. You see there intravesical chemotherapy, and that includes valrubicin, that includes the doublet, and that includes as well the thermoactivated hydrogel, the Gemcitabine, the same formulation we have for the upper tract. Studies showing promising results in the bladder. I didn't have time to show here, but it's going on that space as well. And pembrolizumab is here, and now the gene therapy already incorporated into the guidelines. And for patients who recur or fail or become BCG-unresponsive, again, you see those boxes getting bigger and bigger, alternative therapies, gene therapy, immuno-oncology therapy, in those boxes. So I wouldn't be surprised in the next couple years, we're here talking about the new therapies, other things coming up in BCG, potentially having alternatives or even replacements, not being the standard of therapy anymore. So I'll be happy to take any more questions. Thanks again for the opportunity. Thank you.